So we are super excited to continue this amazing session with Karandeep Singh from University of Michigan. So Dr. Singh is an assistant professor at Learning Health Sciences, Internal Medicine, Urology, and Information at University of Michigan. He's a nephrologist with a background in biomedical informatics, and their team, and he is extremely active in using machine learning methods in modeling electronic health records, register data, evaluations, etc., in support of learning health systems. So he's directing machine learning for Learning Health Systems Lab, which has put out quite a lot of valuable research in the domain of implementation science. So Karandeep, please take it from here.
Thank you. And you guys can see my screen, right?
Yes.
Perfect. So I'll be talking about challenges in evaluating machine learning models. Thanks, Nargis, for that wonderful introduction. So some disclosures: I received grant support from Blue Cross Blue Shield of Michigan and Teva Pharmaceuticals, and I'm on a scientific advisory board for Flatiron Health. So let's rewind back to March of 2020. I know no one wants to do this, but I want to use this as a kind of case study for evaluation. On March 24th, our health system at Michigan Medicine, the situation looked quite serious. We at that point had just gotten our first handful of COVID-19 patients, but we were starting to see those numbers double every single day. And even under kind of a best case scenario, it looked like we were going to approach or exceed 3 times our hospital capacity with respect to kind of what the expected census was going to be. So as we were coming to terms with what that might look like if it were to take place, one idea that was put forth, which was not surprising, this was a discussion happening all over the country, was whether to build a field hospital, with the idea being that the patients who were less sick, the patients who did not need ICU level care, would be the ones to safely go there. And thinking about the reality of this, if we really had 3,000 patients at our doorstep, could we actually evaluate them in detail with physicians, and be able to make really kind of patient medical decisions? Probably not. And I think the thinking was, what could we do to help us in triage at that time if we really had 3 times our hospital capacity of patients sitting at the ER waiting to get in? So I think we weren't the only ones thinking about this. There was this nice article that came out about some of the work that Dr. Ron Lee at Stanford was doing, and they were thinking about doing kind of a test of an AI-driven model to triage, to help triage patients with COVID-19 were things to get really really bad. And so he showed in his presentation, Dr. Ron Lee showed this really nice kind of picture of what that might look like. Here's the Epic Deterioration Index, which is the test he was looking at. And you can see how in this patient, from his presentation, this kind of patient starts off with a score in the 20s, the score goes up to the 50s, the 60s, the 70s. And here's someone who, you might say, this person's getting sicker. First, they probably shouldn't go to a field hospital. And 2, this is someone who likely needs attention because they might be on their way to the ICU. A couple weeks after that, there was a press release from Epic that many organizations had already kind of completed their validation of this score, were already using it for patients. And I think internally, Epic was doing some of their own evaluations, sharing some of these numbers with organizations around how well this model was doing for picking up which patients need to go to the ICU in the setting of COVID-19. Interestingly, though, even though a lot of hospitals were already using this or had this turned on where they could use it in their health system, and estimated dozens to up to hundreds, they were actually using it in different ways. So at Parkview, when they looked at their kind of 100 cases of COVID-19, they found that most of the patients who needed to go to the ICU actually had scores kind of in this middle zone of 38 to 55. Whereas when kind of we looked at this, the data from patients we were seeing, by and large, the highest risk was among patients with the highest score. So kind of on the margin, and similarly, the lower risk was, closer to the lower end of the spectrum of the scale. So just because we kind of had a shared understanding maybe of what the area under the curve of this model is, didn't really mean we had a clear idea across centers of how to use this score to support this kind of a decision making. Now, interestingly, from the original press release that came out, regarding this model for COVID-19, there was this figure showing an example of the way this score might be presented to providers. And so this score of 37 was like in the initial release shown as being kind of a score in the danger zone. Now, interestingly, if you look at the score of 37 amongst COVID-19 patients who came to our health system, this is from our paper in Annals of American Thoracic Society, a score of 37 corresponds to about a 12% risk of going to the ICU or dying, which was the composite outcome we looked at. Now, that's by no means like a low risk. That is high risk. But interestingly, if you had a score that was even lower, score in the 20s, your actual risk of going to the ICU was even higher. So this just goes to show you that, again, when we evaluated this model for this use case, arrived at a similar area under the curve as what was being reported, by the vendor internally. But there was this interesting finding here that just because we have the same area under the curve doesn't mean that we have a shared understanding of what to do with the score once we have access to it to support medical decision making. And I think the other thing that we saw was that predictions don't always change gradually, like what was kind of shown in that picture. Here's 4 different patients, 2 who needed to go to the ICU, 2 who never went to the ICU for their first 48 hours of their stay. And the score is recalculated every 15 minutes. You can see how that patient on the bottom left, who never needed to go to the ICU, looks at varying points like they're about headed to the ICU, and not just the score. If you calculate like a trend on that score, a slope, I mean, they look like, this person's getting way worse. This is it. And they kind of were able to stay out of the ICU. So when you're trying to evaluate these scores, you have to deal with the fact that people's scores do go up and down pretty starkly. And so it's not just kind of this gradual worsening or this gradual improvement over time. And further, I think how you do the evaluation also depends on your use case. So if you have an alert-driven use case, then you can think about kind of some of the things I showed you on the last slide. But you might have another use case like what CT Lin, in his talk highlighted. We have a similar use case for our rapid response team, where they have a dashboard of risk from highest to lowest, and they check in on the highest risk patients across the hospital, kind of no matter where they are. So in that, your calibration might not matter so much, but the way you evaluate it has to do with how you intend to use it. So there's 3 different types of ML evaluation that I'll kind of just briefly talk about. One is to figure out whether the models are generating the correct predictions. So basically, I think when things fail, the first thing you have to assume is that you didn't wire things correctly. And this is where you need to know that whatever infrastructure you're using has access to the most recent scores or the most recent data elements, so that whatever score it's generating is actually reflective of the patient's kind of current state. You need to make sure your variables are correctly mapped. So, if you're pulling a specific vital sign, you want to make sure that that vital sign is being pulled even after your EHR updates, because you might find things drop off as variable mappings get dislodged. And similarly with missing values, sometimes your variables are correctly mapped, but for some reason on your backend, you suddenly start getting a bunch of missing values. And if your score doesn't flag that for you, it'll look like the score has gotten worse, when in fact it's just related to a variable mapping missing value issue. Once you know that you're generating the correct type of scores, then you want to know whether you're actually accurately predicting the outcome with those predictions. So this is what we often refer to as a silent evaluation. And when we do the silent evaluation, you want to get a sense for, is the model good enough? And how good does good enough need to be? And I think if you decide then that the model is good enough, and you then decide that we're going to link a clinical workflow to it, then obviously the final stage here is to figure out whether your model-driven clinical workflow itself is useful. And this is where I think we see the greatest need for clinical trials. But in reality, oftentimes these end up being quasi-experimental designs, just because of some certain times impracticalities around trying to conduct clinical trials in this environment. So some basic challenges, I'm not going to get through all of these because I know that we're a little bit short on time, is, well, should we integrate a model and run it silently in the EHR? Once we implement it, how should we measure its performance? Is it good enough to use, and is it effective when used? So this first point, I'm not going to touch too much on because I think Nigam actually had this in your slide, that we often have to act based on imperfect information. If integrating a model in the EHR was zero work, then we would just integrate every model in the EHR. But because it does involve work, we have to be, pick and choose a little bit. And so that's where having complete information, or the best information you can have, is really important to be able to, choose whether to even pursue that initial step of integrating a model based on what you have available to you. Once you have a model, how do you measure its performance? So I won't get too much into this, but a lot of the disagreements or issues that come up when you see varying results reported in the literature come down to how you define the outcome and how you define time zero. And then although this seems like a relatively obvious thing to do in most situations, where there's some situations where it may not make sense, you generally want to exclude all predictions that you make after your time zero, if the assumption is that that would be too late to intervene. And then you want to look at model performance in two different ways. You want to know at the encounter level how good the model is, and then you want to know how good is any given prediction. But it's not enough to just know one or the other. The reason it's important to know both is that you can end up with a situation where most predictions are good, but every single patient has one bad prediction. And in the case of an alert, all it takes is one bad prediction to generate an alert. Even if 99.9% of your predictions are otherwise good. To the end user, they saw the page come through, even though it was a false positive, because the model leveled out after that initial spike in its score. So how we decide whether it's good enough to use, commonly what you see reported in the literature is area under the curve. You see reports on kind of calibration. And for most things in clinical medicine, we can't get AUCs of 0.99, particularly when we're trying to predict things that are going to happen in the future, where there's some degree of uncertainty. So whether a model is good enough, it doesn't really come down just to the area under the curve, because there are certain situations where an AUC of 0.6 is totally fine. And there's other situations where you would never touch anything unless the AUC was 0.9. And this comes down to, if you were to evaluate a ton of patients, how many patients would you be willing to evaluate to capture one case? When you have a really effective treatment, or where the intervention that you're doing is really pretty painless, it doesn't involve much time, doesn't involve much effort, you may be willing to evaluate a lot more patients to capture one true case. But if your intervention is like taking someone to the OR and operating on them, your number willing to evaluate is going to be much, much, much lower. You're going to want to not evaluate people only when you're pretty certain that they're going to need surgery, because that has a decision with a lot of consequences and risks. So decision curve analysis, I think, is a really nice way and net benefit to at least think about how good a model might be, and specifically to answer the question, is a model better than evaluating all patients? Is a model better than doing nothing? Because many times you can end up in situations where using a model is actually worse than doing nothing. And you'll never discover that after the fact. Those clinicians will find some threshold that they'll say, yeah, that might be a good threshold. I want 90% sensitivity, just give me that threshold. Well, if your 90% sensitivity means you alert on 90% of your patients, that threshold is not really all that useful. And then, the other question that comes up is it better than current practice? And this is where having a silent evaluation can be really helpful, because you can actually see the patients who alerted, were they actually already treated or not? Because that can help you figure out what that added value might be over what people are already currently doing, because people aren't currently practicing randomly, they're practicing based on their existing level of expertise. So there's lots of examples of models being great, but then when you go to link the model to an intervention, the intervention being ineffective. The story doesn't end when you find that a model is good. You then want to make sure that when you link that model to an intervention, that it's actually doing something, moving the metrics that you care about in some kind of positive way, or achieving some other workflow streamlining that has a benefit, even if you're not actually improving any metrics. So I think that's kind of the kind of final step of evaluation, is this step of knowing whether it's effective. So I want to thank a lot of folks from my own institution, a lot of folks who are actually attendees here for collaborating with me on various aspects of this. And I'll turn it back to you, Nargis.